I'm Antoni Chan, reporting from EULAR 2025 in Barcelona. And here at EULAR 2025, we have seen some interesting posters and abstracts in spondyloarthritis. And one that I came across, which I was interested, is poster 0257. And this looking at instruments to assess peripheral arthritis in spondyloarthritis. And this was presented by Dr. Dafne Capelusnik from Tel Aviv, Israel. And I'm very happy that she can actually join us here today to talk about the poster and the abstract. So Daphne, welcome. And I wonder whether you can tell us a little bit about your poster.
Thank you. Thank you very much for the invitation and for your interest in our job. So the idea of this project was to assess different instruments to assess disease activity due to peripheral arthritis. Actually, one of the main objectives of the ASAS-perSpA study, which is a cross-sectional multinational study, was to assess psychometric properties of disease activity scores. And even though there are a lot of ancillary analysis from this study, we had never assessed this. We never approached this objective. So the idea was to look, in this case, since it is a cross-sectional study, to assess the construct validity of different instruments to assess disease activity due to peripheral arthritis, and not focusing only in, for example, ASDAS or BASDA, which are the usual instruments we use in axial spondyloarthritis, but also some other scores from psoriatic arthritis or for rheumatoid arthritis like the DAPSA or DAS 28 or 44. So what we did was to assess the construct validity. In this case, we did that according to the recommendations from OMERAC, through the assessment of the hypothesis of correlations of strengths, and also to see the ability to discriminate between two different known groups. And what we found with our results were that even though all the scores have a good construct validity, apparently the discrimination between known groups is higher in those composite scores, including joint count. So, for example, the DAPSA or the DAS 28 or 44. So, of course, we need more some extra analysis, and this is the first step for the future projects. For example, now there is an ongoing project from ASAS, the ASAS-perSpA project, where we are aiming to assess all the psychometric properties, not only the construct validity, but also discrimination in clinical trials and sensitivity to change or longitudinal construct validity, to finally see which is the best instrument, and maybe to recommend to start using, at least in clinical trials. Then we will see in clinical practice, but at least in clinical trials, what should we use to assess correctly the disease, the peripheral arthritis as a manifestation of the disease. This will be, it's important to mention also, this will be mainly for axial spondyloarthritis and peripheral spondyloarthritis. We are not interested in assess nothing in psoriatic arthritis, which we already have a lot of recommendations. So this will be based in axial spondyloarthritis and peripheral spondyloarthritis.
That is very impactful and quite important. Certainly in my clinical practice, up to 25-30% of our ASAS-perSpA patients may have some peripheral arthritis, and I think the literature also supports that. And with a great drive to do ASDAS, I wonder how many of these patients that we probably miss some of the assessments because we are not assessing the peripheral arthritis. But yet, as you say, there is no validated instrument, if you like, to assess these patients. So I think it's a really important study. You did have some PSA patients, I think, in your study. And how does that, fit with the results and the assessment? Because I noticed there was also DAPSA being used in the study.
Exactly. Good that you mentioned. The cohort includes the ASAS-perSpA study includes patients with axial spondyloarthritis, peripheral spondyloarthritis, and psoriatic arthritis. So we did the entire analysis in the entire population, so including all the diagnoses, and then we repeated separately in each one of the phenotypes, and the results were the same. Again, the composite scores, including joint count, were the one best performing for discriminating in between known groups. So even, of course, in psoriatic arthritis, but the results were the same also in axial spondyloarthritis and in peripheral spondyloarthritis.
Yeah, it looks like the scores where there were, joint counts, DAS 28, DAPSA, they perform better in the performance, and DAS44 as well. One of the things that I think you were looking at standard mean differences, SMDs of 0.8 as your cutoff. Were you surprised that CRP didn't come out as strongly in that?
Yes. Only did it in the axial spondyloarthritis group, but yeah, in psoriatic arthritis and in peripheral spondyloarthritis it didn't show a good discrimination between non-groups. It was also a surprise for us.
Yeah, because we always like to think that if you got peripheral arthritis, like a swollen knee or ankle, your CRP would be high, and if you have it more on the axial, up to 50% can be normal. But I think in this study, it probably shows that it's not as sensitive as we may think. But we, of course, will have to see future studies.
Of course.
That's very interesting. So what would be your sort of next step for this? In terms, how would you kind of narrow this down to a more specific assessment tool?
So as I was mentioning, the ASAS-perSpA project it has already started. So what we are doing is we want to look in the literature whether there is data in observational studies or in different cohort studies. Of course, we will have data for ASDAS or BASDA. We will have less data for DAPSA or DAS in patients with spondyloarthritis. So the idea was also to analyze them. So we are one of the plans we have is to ask for the randomized controlled trials data, as much as possible randomized controlled trials, and to calculate the DAPSA for all the scores, but also the DAPSA for the DAPSA and the DAS in some of the versions. Another point, interesting point, is that the DAPSA is usually calculated with the swollen joint count 66 and tender joint count 68. And usually trials in axial spondyloarthritis only have the joint count of 44. So I also present in this EULAR an abstract of the development and validity of the DAPSA 44. It was mainly developed to be used in this project. So we will be able also in randomized control trials to calculate this DAPSA 44 to see how is the performance. Of course, if there is some trials where the 66 or 68 joint count is available, we will use the original DAPSA, but in case we can, we will have that option to do it. And we will calculate, as I said, also the discrimination in clinical trials and also the sensitivity to change, which was not possible in this study.
That will be really useful. Of course, you got 28, you got 44, and then you got 68. So in terms of the assessments, I think the message is, for now, until we get a validated score, is to do at least one of them. It's better to assess their peripheral arthritis compared to what we are doing right at the moment. In your study, 61% were males, and you had about 4,000 over patients. We always like to think that peripheral arthritis is more female than male in terms of their phenotype. Do we think this is because it's historical and maybe in those times we didn't look out for them as much?
Yes, but also it can be that because in the ASAS-perSpA study, there are also a lot of patients with axial spondyloarthritis with peripheral manifestations, some of them. But if we see the percentage of patients in each one of the phenotype groups, they are mainly axial spondyloarthritis patients.
Yeah, so it's a context of axial spondyloarthritis with peripheral symptoms. Yeah, that's very interesting, and that's a very nice presentation, and we obviously look forward to your future work and how we can use this in the clinic. I thought this was a very practical presentation. This is why I wanted to discuss this because I think it's useful in clinic for us. So Dafne, thanks very much for your time and for presenting this work. We look forward to for future meetings to see how this develops further. Thank you.
Yes, thank you. Bye-bye.
Bye.